So I think the MA.17 trial initially was a little bit overwhelming when they showed that the major effect was on contralateral and local recurrence, 3% versus only 1% with distant recurrence. But I think the trial was put into focus, at least for me, with the subsequent day presentation of the 20-year overview, where they showed that there is a continued recurrence out to 20 years, and this trial was reported only at a median follow-up of a little over 10 years. So even though the trial seems that it is a late reporting, it's really somewhat young in terms of the overall history of the natural history of breast cancer. So I think that we haven't seen all of the relapses to give us the full input. So again, I think one of the themes that continues to emerge is that we have to do a risk analysis of who really is at risk for these types of problems of late recurrence. The BCI, the Breast Cancer Index, is one of those tools out there that many of us are using in practice. The same as in the very beginning when we only had adjuvant online, and so we would be trying to use that to figure out what a person's risk of recurrence was and should we give chemotherapy in addition to anti-hormone therapy. Then the 21 gene recurrence score came out, and we said, hey, the adjuvant online, that's a statistical evaluation looking at hundreds of patients, but the 21 gene recurrence score is you, so it's going to tell us about you. So I think the BCI or other tools that come along like that may help us individualize and personalize that discussion for each of our patients. For now, we are actually going over the data with my patients, and I have copies of the graphs on my iPhone, and so we pop them up and we look at the 20-year recurrence rates by particular tumor and node size, and then have that discussion with the patient, what their thoughts are.